Welcome to SDHC's Health and Wellbeing podcast. Before we begin, we want to emphasise that the information shared in this podcast is for educational and informational purposes only. While we strive to provide accurate and up-to-date content, it is not a substitute for professional medical advice, diagnosis or treatment. Always seek the guidance of your doctor or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. Remember, your health and well-being are invaluable, so prioritise consulting with a medical professional for your personalised care. Hi everybody, you're listening to the Health and Wellbeing podcast from Hillbrow Health and Wellbeing and SDHC with your host, Dr Nick Harvey. The purpose of this show is to help people understand how they can help themselves and others with their health and well-being. Every episode, I interview an everyday expert to understand the latest evidence and advice on how to improve your own health or help others. Today, we're discussing a growing health issue that's affecting more and more younger adults, type 2 diabetes in people under 40. And we're joined by a very special guest, Dr David Lipscomb. Dr Lipscomb's a consultant in diabetes at the award-winning Diabetes Care for You service at Sussex Community Foundation Trust in Brighton. He's been the clinical lead for diabetes at the Sussex Health and Care Partnership between 2019 and 2024 and previously served as a clinical lead for the South East Clinical Network. Dr Lipscomb also holds the role of course principal for the Diabetes and Primary Care course at Brighton and Sussex Medical School, where he's shaped education for healthcare professionals on the management of type 2 diabetes. With a strong focus on value-based care, clinical leadership and medical management, Dr Lipscomb is passionate about improving diabetes care and tackling the rising incidence of type 2 diabetes in younger adults. Well, welcome. Thank you for joining us.
Thank you, Nick. Pleasure to be here.
Yeah, it's great to have you here, and I'm kind of amazed by everything that you've done in diabetes locally and more kind of regionally as well. Before we dive into all of that, I know that you've got a lot of commitments in your family, and you're telling me about your gym you have at home. So how do you manage to balance all this? Tell us a bit about.
Well, I've got a very good wife. I think really that's the truth of it. Called Bernie, who's a practice nurse, an advanced nurse practitioner in diabetes, and she organises everything and keeps me focused. You know, it's very easy in medicine, as you know, to spend the whole of your life just focused on your job. But it is very important, particularly as we get that little bit older, to try and develop outside interests. So yes, I do enjoy going to the gym, and I enjoy long distance walking. So I've just walked the Cotswolds Way, which is 102 miles in 7 days. Hence the reason why I'm wearing trainers to allow my feet to recover. And I think getting out, doing exercise, particularly with friends, is tremendous both for mind and body.
Absolutely. I find it's interesting, isn't it? Doing things with friends is very different to doing things on your own. And I think both are really valuable, aren't they? I find a lot of headspace in just getting out on my own.
Oh, yeah. No, it's brilliant. Yeah, absolutely. And, you know, I found that doing Tai Chi, meditation, those sort of things are great.
Yeah. Fantastic. Well, with your approach to things like that, I can't wait to get you stuck in at Hillbrow. I think really fits.
Great.
And of course with the vision as well, because I think you and I probably share quite a lot in terms of how we feel about preventative healthcare, because we see the harmful effects down the line, don't we?
100%. So, you know, you spoke about my passion for treating people that live with diabetes and treating people that live with obesity and in my previous role, endocrine problems. And, you know, we absolutely must focus on prevention at every stage. So whether that's primary prevention, so preventing the condition to begin with, secondary prevention, preventing the complications of that condition, and then, if you like, tertiary prevention, which you can think of as treatment of those complications to try and stop, you know, end stage complications occurring, such as blindness, renal failure, loss of a limb. And one of the things I think that we don't do as well as we can is that focus on prevention at each stage. And I think helping to encourage and to inform people about their choices, because it often is choices, even though we don't necessarily see it as that, it is choices that people can make at an earlier stage in their life to prevent things happening as we grow older.
Mm-hmm. I've become more and more fascinated with the science of habit as well, because I think the choice is probably around how we develop habits rather than the choice in the moment, which we often focus on, don't we? And actually, I think once you're in a moment and your brain has received the cue to do an unhealthy habit, whatever it is, it's too late, isn't it? Yeah. And that's all around, we were talking before we came on air, around the things that are put in front of us in our society, as well as what we put in front of our eyes. And
definitely. If none of us responded to advertising, there wouldn't be any. So, of course, we all respond to external cues, even if we don't necessarily realise that. That flash up of a name that we know during a sports game or whatever is there for a reason. And we know that, whilst social media has done a tremendous good in our society, it also has the potential for tremendous harm. And, those algorithms that drive social media are designed to keep bringing us back. So being able to take a break from that, as I said, get out, leave the phone behind, leave our smartwatches behind, and leave all of that behind and get back to our natural environment is tremendously important.
Mm. So you're here to talk about type 2 diabetes and in particular in under 40s. Now, when I was at medical school, you hardly heard of this. So what's going on? It really is on the increase, isn't it?
Yeah, it is. It is, I'm afraid. So now, the past few years, the first time ever, people living with type 2 diabetes under 40 outstrip the type 1 population in that age group, which, again, as you say, when we were at medical school, one would never have thought that was possible. And certainly until the 1980s, 1990s, you would never really see anybody in youth in under 18 with type 2 diabetes, but that is becoming increasingly common also. And the question, of course, is why? So we all have a genetic predisposition, some of us stronger than others, to developing type 2 diabetes and other metabolic problems. But our environment has changed in all recognition really over the last 40, 50 years. And it's that obesogenic environment that has driven the rise in type 2 diabetes in all age groups, but particularly in young people.
Should we just take one step back just to understand what's the difference between type 1 and type 2 diabetes, just so people understand that?
Yeah, so the two main forms of diabetes are type 1 and type 2, as you've said. Type 1 diabetes is an autoimmune condition, so where your body's immune system attacks the insulin-producing cells of the pancreas, the beta islet cells of the pancreas, and over time destroys enough of those to give the clinical picture and the blood tests and so forth that we do to diagnose diabetes, or diabetes mellitus. Type 2 diabetes, which is 8-9 times as common as type 1 diabetes, is due very much to an inflammatory response of your fat cells. So you get excess fat in the liver, excess fat in the pancreas, and excess fatty acids in the pancreas, which over time attack the pancreas and both cause insulin resistance, but also insulin deficiency. And it's the combination of those two things that again give you the clinical picture and the blood diagnosis of diabetes mellitus. And there's a few other what we've termed MODY, maturity onset diabetes of the young, because in years past we used to classify the type of diabetes by age group, and then we realized that wasn't true. And then we tried to classify diabetes by treatment. So what you may remember, IDEMS, insulin-dependent diabetes, and NIDEMS, non-insulin-dependent diabetes. Well, that wasn't true either, because people living with type 2 diabetes often require insulin also. So when they first started to notice there were other groups of people with slightly different types of diabetes. They label them MODY, so maturity onset diabetes of the young, which is obviously a misnomer. And those are single gene disorders, usually. Well, not usually, they are single gene disorders that cause diabetes. And the reason why that's important in this discussion is that, like any other part of medicine, making the right diagnosis is critically important to trying to provide the best advice and treatment for the person living with diabetes. So particularly in those under 40s, we will often do additional investigations to confirm or deny whether it is type 2 diabetes as the cause.
Mm-hmm, mm-hmm. Thank you. So now we've got that out in the open.
Yep.
Type 2 diabetes we're talking about, which is where you mentioned that we get increased fat cells that cause inflammation and resistance to insulin, as well as reduced insulin. So what is going on in our environment and the modern lifestyle that's leading to it becoming more and more common?
Yeah. So when I left medical school in 1995, the prevalence of diabetes in this country was about 3%. The prevalence now, the diagnosed prevalence is around 7%, and there's probably another third on top of that are undiagnosed. We're getting towards 10% of people in this country have type 2 diabetes. As I say, most diagnosed, but some certainly not diagnosed. And we've also got people with what we call non-diabetic hyperglycemia, or what our American cousins call pre-diabetes. And there's probably around 10% or so of the population that in addition have that on top of those with type 2. So you're looking at about 1 in 5 people in this country have some form of dysregulation of their glucose metabolism. Now, you ask me why. Well, I think it can't be genetic. So we know that type 2 diabetes has multiple genes that play a role in its development. But our genes don't change over 30 years or 50 years. It just doesn't happen that quickly. So it must be environmental as the main trigger behind people developing type 2 diabetes, particularly in a younger age group. And I think it is very much our obesogenic environment where high density calorie foods are available. When we talked earlier about sweetened beverages, and indeed artificially sweetened beverages as well, all play a role in increasing your risk of developing type 2 diabetes. The other side to that coin is that, as well as becoming more focused on these highly calorific foods, we've also become less active as a total population. The third thing, and this isn't germane to young people with type 2 diabetes, but the whole population of people with type 2 diabetes, is that we have an aging population. And type 2 diabetes, like many other conditions, does tend to get more prevalent as we get older. Mm-hmm. So in your over 75s, over 80s, you're thinking of around 25% of that population having type 2 diabetes. But the reason why we're talking specifically about younger people is because of the impact that early diagnosis of type 2 diabetes makes on their life, both in terms of the length of life, but also in terms of the quality of life from the complications that we discussed briefly.
Thank you. Can I just challenge you on the first point then? It was about high calorie intake.
Yeah.
Carbohydrates or any calories?
So there's enormous amounts of debate around that, and I'll give you what I think. And I think it's calorie intake. So it's chronic excess calorie intake versus what you require. So,
but there is evidence of restricting carbohydrate intake to improve your diabetes risk of developing.
Well, so that's again a much debated aspect of healthcare. So I think that probably most people in this country take excess carbohydrates versus what they need. So I'm not a dietitian, Nick, as you know, but my feeling is probably most people will be perfectly replete with around 150 grams of carb a day, but most of us will take in considerably more than that. Now, there are definitions of a low and a very low carbohydrate diet. So a low carbohydrate diet being less than 120 grams, and a very low carbohydrate diet significantly less than that. Now, there is significant move to look at specifically low carbohydrate diets as being a panacea. I personally don't believe that's the case. Low carbohydrate diets will help you to lose weight. Whether that weight loss is sustainable is another matter, but that's perhaps the same with many forms of dietary induced weight loss. But I don't think that low carbohydrate diet gives you extra special properties over a calorie restricted diet, and there is some study evidence to go alongside that.
Thank you. That's really helpful. And I think it probably highlights more than anything that the approach to any lifestyle changes, it's got to be personalised, hasn't it?
Absolutely. You know, I can't remember who said it, but you know, the best diet is the one that the person can sustain and is available and affordable. And you know, that I think it's one of the problems that we have is that you know, cheap, high density calories are very affordable, and the foods that perhaps we ought to be eating more often appear more expensive.
Mm. Mm. And that leads us into the question around what the government can and might do to help this whole situation. I know you've got lots of thoughts on that.
Yeah. So you know, if we are to prevent, you know, we are genuinely, I think, at a turning point. And if we carry on as we are, then we will. When we're already starting to see a leveling off of the age at which people die, and I think that if we carry on the way that we are, we will start to see a decline in life expectancy for the first time for many years. That decline won't be universal across our population. It'll be more enhanced in the people that are most deprived and people from ethnic majority groups across the country, and that's a real concern for me. Now, what can the government do about it? Well, the government hold the levers of laws and legislations, and I think they've been relatively nervous so far about pulling those where foods and so forth are concerned. They have done some good things. I think, you know, the sugar tax, as far as it goes, is positive. Obviously, the salt tax before that was positive. In Scotland, they've got a minimum pricing for alcohol, which again is positive. But I think there is the opportunity, and I think, to be honest, from a health point of view, the need to go further. And that's not because I believe in telling people what to do. I don't. I believe in advising them and people making their own choice. But we do need to help people to make choices that are most likely to be in their interests, as opposed to in the interests of large organisations. So I think looking at taxing high calorific foods in a way that we don't at the moment is one thing. Looking at extending the sugar tax to where it was originally meant to be, I think, is another thing that could be looked at. And also positive. So those are sort of almost negative laws and negative thoughts. But I think positive thoughts is to encourage organisations, particularly large organisations, in terms of the health of their staff, in terms of looking at, you know, I know you run an excellent gym here, you know, looking at subsidised gym membership and having a tax break for that if a company does that, looking at tax breaks for companies in organising healthy activities for their workers. You could look at tax break for a large company having the diabetes prevention program coming in on site, for example. So there's lots of things that the government could do on a societal level, which I think would help us greatly. You know, you could look at taking VAT off sports clothing, for example. Yeah, that's literally just coming to my head.
But yeah, absolutely, it needs time and thought.
Yeah.
So I'm going to take you back to our, say, 40-year-old, 30-year-old who has developed type 2 diabetes. And one of the questions I get as a GP is, I don't want a load of medications. I feel fine, thank you. What's the message to people who have been diagnosed with diabetes and kind of think, I don't have it. I feel fine. Why bother?
Yeah. So one of the difficulties in treating people living with type 2 diabetes is they often do feel fine, which is a good thing, of course, but they feel fine until they're not. And once people are not fine, it's often quite difficult to, or if not impossible, to reverse the damage that's been done. There's something that people talk about as in terms of avoidable glycemic burden, which is a posh way of saying, glucose levels are higher than they should be, and that will over time cause damage. We can go into that if we need to, and what our job should be as clinicians is to try and reduce the impact of that type 2 diabetes diagnosis as much as humanly possible. So I absolutely believe in the use of lifestyle to try and ameliorate most medical conditions, but certainly type 2 diabetes and those living with obesity. However, lifestyle alone often isn't sufficient for a number of reasons. It's hard to stick to. It's sometimes hard to do the amount of activity day in, month in, year in, that will sustain enough changes in your metabolic state to get you where you need to be in terms of glucose control. In addition to that, we know that type 2 diabetes is a progressive condition. So over time, your beta cells, those are insulin-producing cells of the pancreas, will reduce. So what worked for you before or now may not work for you in the future. And that's something that people don't always talk about. But I think it's really important, because very often people come and see someone like ourselves or my wife, and they will feel they failed because their glucose levels have gone up. Their HbA1c, which is one of the long-term measures that we use to gauge glucose control, may have increased. And people often blame themselves for that. And very often it is not down to the person. Very often it is down to the fact that their condition has progressed. And that's something that we expect. So, many of the studies that we're both aware of, the original studies called the UKPDS study and studies going forward, have all shown that whatever medicine you use, eventually you need another one. Now, and that's not about you and I wanting to give people medicines because we want to give people medicines. It's about we're giving somebody a treatment to prevent a complication later on. So I tend to think of it, the way I often explain it to people living with diabetes is that, when we were kids, we didn't have to wear a seatbelt in a car. Now you have a seatbelt, you have an airbag, you have some sort of collision prevention system. So we've got better tools, we've got better abilities to prevent bad things happening. But still bad things do happen. But surely what we all want to do is to reduce the chances for those individuals, and therefore reduce the chances for the population of people that we serve. Because for me, I want people to live a healthy, happy and full life, and controlling their diabetes will definitely help them to do that.
Thank you. We're often talking these days about, rather than lifespan, a health span as well, isn't it? And I think one of the cruel things I see with diabetes is that it does have a massive impact on health span, doesn't it?
Yeah, I think that's a crucially important question, Nick. So you're absolutely right. So often we'll hear people saying to us, well, I don't care if I die. And often I don't think that's true, but nevertheless, people do say it. But you're right. So, people living with type 2 diabetes, particularly those who develop at an early age, seem to have a more aggressive phenotype. So the condition seems to progress more swiftly than if you're diagnosed later in life. If not treated optimally, there is an increased risk, a significantly increased risk of developing complications 5, 10, 15 years after diagnosis. And by and large, as you know, those complications cannot be reversed once they've occurred. So even though you feel well, now, I think of controlling your glucose levels and other risk factors, blood pressure, weight, lipids, cholesterol, all those sort of things, as part of your pension scheme for yourself. So you're paying in now to get something later on, because it's a great study scientifically, but alarming study called Today from America, and these are people living with type 2 diabetes that were diagnosed mainly in their teens, and they are developing the sort of complications that we would see in people in their 60s and 70s, in their 20s and 30s. So these are people in their 20s having a heart attack or a stroke, not due to something very unusual, but due to the same sort of things that we would see, unfortunately, not infrequently in older age groups. People in their 20s developing heart failure. None of us would wish that on anybody. And if we need to act aggressively in people's interests to try and prevent those things happening.
So we're talking about complications. You mentioned a few there, one of which was stroke, heart attack, heart failure, when the heart's just not pumping effectively. What else is there? And this is going to sound like a bit doom and gloom, but I think it's important, isn't it, to be really clear what can go wrong, because there's so much we can do to stop it happening.
100%. So, I'm not going to list every possibility, but yes. So, there's sort of two classical areas of complications that we talk about in people living with diabetes. One is microvascular, so it's small blood vessels and nerves and those sort of things, and kidneys. And that's directly related to damage from high glucose levels. And then there's what we would call macrovascular complications. So some of the things we mentioned, heart attacks and strokes and heart failure, high blood pressure. And those are related more to inflammatory blood problems in the larger blood vessels, plus additional accumulation of cholesterol in those blood vessels. But we now knowing that there's additional complications of living with type 2 diabetes, and particularly living with type 2 diabetes and obesity. So there's increased risk of many of the common cancers. There's increased risk of liver problems as well, which often is not thought of as being associated at all. So there's stats from America showing that now what we used to call non-alcoholic fatty liver disease, or now called MASLD, metabolically associated liver disease, is now outstripping alcohol as the most common cause of liver cirrhosis. And so our previous approach to managing people living with type 2 diabetes was very much based on, let's control their glucose, and if the weight goes up, that's okay. But I think our approach now is very much more, we need to manage weight and glucose levels alongside each other to try and get the maximum benefit in terms of reducing complications later on. And that's certainly what I do.
What do you find motivates? Because I find that sometimes talking about heart attacks and strokes and things don't motivate people, but I found, so young men, for example, when you talk about erectile dysfunction, absolutely. That's a motivator. Going blind is another one, isn't it? Are there any others that you find are really useful to kind of...
So people quite understandably, as we all do, worry about developing a disability. Often people, in my experience, worry not so much about themselves, but about being a burden to other people. So things you've mentioned are exactly correct. So, diabetes was the most common cause of blindness in working age adults. It isn't any longer. It's now the second. We've also noticed a significant improvement over the years in heart attacks and strokes with better treatment. But it's still a problem. But there's additional complications developing, which I think are important. So diabetes is by far and away the most common cause of lower limb amputation, which is often really concerning to people, or the risk of that really concerning to people. It's also an increasingly common association with dementia and memory loss as well, which again I can understand would be really concerning to people. These are often concerning to people in their middle age rather than the younger people. But I think certainly in young men concerns about erections and so forth, important, and also concerns about both in men and women about fertility and pregnancy. So, with that younger age group, so it used to be, because I used to be part of the diabetes in pregnancy service here in Eastbourne years ago, and most of our patients would have type 1 diabetes, but now that demographic has changed quite a bit. And in a lot of pregnancy clinics, there's more people living with type 2 diabetes in terms of those coming with pre-existing. And we know that those women with pre-existing type 2 diabetes are not as well prepared for their pregnancies as those living with type 1. So helping to control their glucose levels before pregnancy, helping to control their blood pressure if that's a problem before pregnancy, making sure they're on the right dose of folic acid at least 3 months before pregnancy are all really important things about reducing complications for the person, but also for their offspring.
Thank you. I think that's enough of the doom and gloom, isn't it?
Yeah.
Let's talk about what we can do, because that's exciting, isn't it? I think there's loads of things that we can do. I suppose a lot of what we'll talk about is medications, but listening to you was reminding myself of also just the eye screening, for example, that's done, and how amazing that it is at detecting problems so early.
That's brilliant. It's one of the best things that we've, so when the National Service Framework for Diabetes started in about 2003-04, before that, there wasn't a national system of eye screening. Before that, it would be people like you and I looking into the backs of people's eyes with a direct ophthalmoscope, which was obviously better than not doing anything. But even in the best of hands, that would still miss sight-threatening retinopathy. And the diabetic eye screening program, funded by the National Service Framework, and my colleague Sue Roberts was the lead, that transformed care. And when you talk to people that practice in other countries, that's one of the things that they wish they had. Mm-hmm. It's great. And, in terms of the impact that's been made also, so I looked at a study a few months ago from the Lancet, and they were looking at causes of, sorry to go back to a bit of doom and gloom, but it is important, causes of death in people that live with diabetes and without diabetes in 2000 and then sort of 2019. And there has been a significant improvement or reduction in the death rate in people living with type 2 diabetes, such that it's now similar to those without diabetes around the turn of the century. So that's down to the preventative care that's been done in primary care, to be honest, and qualifying the quality outcomes framework. But there's still a gap. Now, the most common cause of death in people living with diabetes is not cardiovascular disease anymore, which is great, but it's now cancer. So that's what I'm saying. We need to do all the things we're doing, but we have a mandate to do more. So in terms of what that more is, so again, when I started looking after people living with diabetes around 1999, then we had some drugs and they were good, but we now have other interventions, other drugs, much better than we had before, transformative drugs. But also the use of bariatric surgery as well is much more prevalent now than it was then, and I think needs to have a much bigger role in the pathway of managing people with type 2 diabetes, particularly the younger people. Did you want me to talk a bit about the drugs themselves?
Go for it then.
All right.
Especially since you're talking about bariatric surgery, I guess brings to mind one particular group of drugs.
Sure. Yeah. So the most common and first line drug that we use in this country for diabetes is one that's been around, even before you and I were in short trousers, which is called metformin, and it's been around probably 65, 70 years now. And it's a very good drug. It works. It helps to reduce glucose levels. It's weight neutral, which is important for people. It has a low risk of low glucose levels, hypoglycemia. And the UK PDS study showed that it provides some cardiovascular protection over time. So that's our sort of starter for 10 in most people. Like all drugs, and like all things, there's no such thing as a free lunch. So of course there's a potential for side effects. Most of those are related to bowel side effects, and those can be minimized by taking it with food. Sometimes we use a sustained release version, which tends to have lower side effects, but that's a very effective drug if tolerated. And then if if people need more than that to get them to their target glucose levels or target HbA1c, there's a drug that's been around probably around 10, 15 years now, or class of drug that we would use next in most people, called an SGLT2 inhibitor. And that's the way that drug works, is that it basically stops you filtering glucose in your kidney. So it blocks the channel, sodium glucose transporter channel, or one of them, and then you pee out more glucose. But it also has other very impressive effects as well, but not related to its glucose lowering effects. So we talked a bit about prevention of cardiovascular disease, which is really important. So if you want to do that, which we do if you want to do that from reducing glucose alone in type 2 diabetes, it will take 5 to 10 years of treatment to do that. And some people would say more, but a long time. Whereas these SGLT2 inhibitors will tend to reduce your risk of a cardiovascular event or cardiovascular death in weeks. So the first study I saw was something called EMPA-REG in Sweden, I think it's 2016, and they showed the graph showing the improvement, and people clapped because, within sort of 40 days you saw a difference in people dying. And that's great, because that's what we're here for. We're here to help people to live longer and live more healthy lives. And it also reduced risks, or these class of drugs also reduce risks of people developing heart failure. They also reduce risk of you being admitted with heart failure if you've got it already. And they're being used now outside of diabetes because they also reduce your risk of progression of kidney problems as well. So these are transformative agents.
And on that, because you mentioned you might add it if the sugar levels aren't so controlled, but in a proportion of people will use it even if they're controlled well by them.
100% correct. So you and I spend our days looking at things like Q risk, and so your risk of cardiovascular events, Q risk 2 or Q risk 3. And the NICE guidelines, the National Institute for Clinical Excellence guidelines, recommend that if your Q risk is more than 10%, so your risk of a heart attack or stroke over 10 years is more than 10%, we should add in an SGLT2 inhibitor, whatever your glucose levels are, as soon as you're on a maximum tolerated dose of metformin. And I firmly agree that's right. I don't think that happens as often as it should in practice, because we've grown up in a sort of glucose-centric view of diabetes rather than a holistic view of diabetes, which is what we try and practice and what we try and teach at the medical school course that I run. Because, it's not just about the numbers, it's about the person. And so you're treating the person, you're not treating, a person is just not a conglomeration of their numbers. You're trying to treat somebody holistically, and these SGLT2 inhibitors are a truly holistic drug, and I think we will find out they'll be used even more widely outside diabetes than they are already.
Mm-hmm. Yeah, they've really transformed things, haven't they?
Yeah, they have, and I'm convinced that they've reduced irregular heartbeats as well.
Mm-hmm. Mm-hmm. And so for listeners, these are medications like empagliflozin, dapagliflozin, canagliflozin. They all sound like flozin.
Yeah, that's right. Yeah, some people will call them flozins, but yeah, SGLT2 inhibitors.
So what's next?
Right. So those are now what I tend to do next in terms of treatment is I feel that the incretin hormones are a very important part of diabetes, and particularly a group of drugs called GLP-1 or GLP-1 stroke. Sorry about all these abbreviations, chaps. GIP analogs. Now these are really special medicines in my view. Special because they're effective, special because again they are transformative in terms of what we have now that we didn't have before. The SGLT2 inhibitors do tend to help people to lose a bit of weight, sort of 2 to 3 kilos on average, which is welcome, but not transformative in most people. But the GLP-1, particularly semaglutide and tirzepatide, which is the first of its class, will help most people to lose 10 to 15% of their body weight. Now, we know that people living with type 2 diabetes, whatever treatment you use to try and help people to lose weight, they don't lose as much weight as those without type 2 diabetes. So often people that are using it for weight loss outside of diabetes will lose more than the sort of quotes I've just given you. But within diabetes, those are sort of perfectly reasonable percentages that a lot of patients get to, somewhere between 10 and 15% of their body weight. Now, though, that's a really significant percentage, because if you want to remit diabetes, and I use that word carefully, I don't use the word reverse, I use remission is a much better term, I think. Through whatever means, particularly in the early stages, you need to lose around 10 to 15% of your body weight. If you want to prevent type 2 diabetes, in those at a high risk, you probably need to lose around 5% of your body weight. And there's a guy that I truly admire and respect called Professor Roy Taylor from Newcastle, who's done some absolutely pioneering research in this area. So anyone who wants to look up Roy Taylor and his partner in research called Mike Lean from Glasgow. And they've done a number of studies, and particularly two famous ones called Direct, where they put people onto a low-calorie diet, so around 800 kilocalories a day. These are people with type 2 diabetes of fairly recent onset, fairly recent meaning 6 years or so or less, and soups and shakes, 800 calories a day plus some green vegetables for 3 months. And the vast majority of people that could tolerate that diet, because it's quite a considerable undertaking, remitted their diabetes with no medicines. Now that's great. But the difficulty is that, not everyone's willing, able, or even willing and able to tolerate that massive lifestyle change. But what he showed very nicely is that that strips the fat out of the liver, that strips the fat out of the pancreas, and things work much better. So I'm a simple person. Lifestyle is great if you can tolerate it, but we shouldn't deny people who can't. So if you can't, then that's absolutely fine, and we're not here to make a judgment about you as a person. We're here to make a judgment about your condition and to help you to manage it. So for me, using medicines to help people to lose weight is perfectly fine and completely necessary. So yeah, so I use those drugs regularly. As you know, Nick, we've had some difficulties with supply over the past few years, but they seem by and large to be ironed out now, thank goodness. So yeah, I think they're great drugs. And there's, in terms of semaglutide, that drug has good evidence of reduction in cardiovascular events. We don't know yet that for tirzepatide, but hopefully that trial will be published this year. But yeah, they're great drugs.
Revolutionary, really, aren't they?
Yeah.
And
the first of many, actually.
Yeah.
First of many. So there's around, to my knowledge, around 40 additional compounds in various stages of development. So I talked about a dual agonist, which is tirzepatide. There's a triple agonist. There's a number of those on their way at various stages in development, and early studies are suggesting a 20% weight loss. And as you alluded to, these are all injections, usually once a week. There's another drug called Mariatide that's going to be a monthly injection. So and there is an oral version of semaglutide. There are other oral GLP-1s probably going to come onto the market in the next 2 or 3 years.
Mm-hmm. Fantastic. So they're the kind of mainstay, aren't they?
I think so. And for me, I would tend to use insulin much later on in the treatment regime than perhaps we would have 10, 15 years ago, for the reasons I've said, because insulin is an excellent treatment for diabetes. There's no doubt about it, but if you can delay someone going on to insulin safely, then I think that's a good thing.
When we talk about medications, I just wanted to bring up statins.
Yeah.
Some people ask about aspirin, so I wondered what your thoughts were about that.
Right. So there's been a lot of research. We'll come back to statins, but yeah, been a lot of research into aspirin more, and they do tend to reduce your cardiovascular events a little in primary prevention. What they do, though, is almost over a population, they almost equally increase your risk of bleeding. So that's why they're not in the guidelines in terms of primary prevention. Secondary prevention, antiplatelet agent, absolutely, that's well proven. But for primary prevention, I don't tend to use them for that reason. And as I say, they're not in the guidelines, either national or international. Statins, on the other hand, I think are, again, a transformative medicine. Now, statins have received a lot of bad press over the years. Most of it is unwarranted, in my view. They are, there's no doubt about the fact that they reduce the risk of heart attacks and strokes. There's one study looking at just people with type 2 diabetes with statins, specifically with atorvastatin, 10 milligrams, which is called the CARD study. Now, that was published probably 10, 15 years ago, maybe longer than that, actually, but anyway, good long time ago. And the CARD study was stopped early. The reason it was stopped early was because the size of the benefit in the statin group was so significant that the trial moderators felt it was unethical to continue. So, you can either believe, people on social media, or you can believe the scientific evidence.
Mm. The muscle aches thing is a big thing with statins, isn't it? And what's fascinated me is the realization of this study that looked at placebo versus statin, and 90% of the people on placebo also had muscle aches.
Yeah. So there was a really nice study, published probably 4 or 5 years ago now, looking at people that felt they couldn't tolerate statins. Because you're right, the most common side effects of statins is muscle aches and pains. But one of the most common things of getting older is muscle aches and pains, right? So they looked at people that felt they couldn't tolerate statins because of muscle aches and pains. And they did a blinded study, so neither the patient nor the treating clinician knew whether they were taking placebo or a statin. And something like 80% of those that felt they couldn't tolerate it were absolutely fine when they didn't know what they were taking. So there's no doubt that muscle side effects are real. But, the statins do suffer from the nocebo effect, which is the opposite of the placebo effect, i.e., I think it will do me good, and it does. Statins do suffer from, I think I'll get a side effect, and I will.
Fascinating.
So, I think they're very effective. I think they're very important. And, certainly, we should be using them frequently in people with type 2 diabetes.
So then we've talked about a lot of the monitoring that happens for complications, and people be used to going, to their GP predominantly for that, and to the eye screening. One key thing, and you mentioned that keeping an eye on the sugar is it shouldn't be the central thing, but it is a significant part, isn't it?
Absolutely.
And we now measure something called a HbA1c. Do you want to just explain that, and because I think there's often a lot of confusion on it.
Yeah, sure. So the HbA1c, hemoglobin, so it's part of the hemoglobin molecule, and your red blood cells tend to live around 120 days. And glucose binds to that. And so we can measure, or someone can measure in a lab, or sometimes at a point of care, the percentage or the amount of HbA1c. And so different percentages, or now we use a reading called millimoles per mole, different levels of that give us an idea of risk. So it's a way of us measuring risk of potential complications over time. And it gives an approximation of what someone's glucose levels have been over the last 2 or 3 months. So in all the diabetes studies, people will look at HbA1c levels and try and plot someone's risk. So for different age groups and different levels of frailty and life expectancy, we will do different recommendations in terms of what we would see as an optimal HbA1c. We also use it for diagnosing diabetes as well. So in terms of what people often ask me, well, what's a normal HbA1c? So a non-diabetic level of HbA1c, completely normal, is less than 42 millimoles per mole. Now, 42 to 47 inclusive is this non-diabetic hyperglycemia category, or as I say, Americans call it pre-diabetes. And then 48 or more gives you a diagnosis of diabetes. And if you have no symptoms, we advise repeating that test, usually within 2 weeks. Now, we also use it for monitoring. So again, different populations, or one would look for different levels of HbA1c, and like all tests, of course, there's always potential pitfalls. So, for example, iron deficiency will tend to increase the HbA1c forcibly. Other conditions that will chomp up red blood cells will tend to lower the HbA1c forcibly, and thalassemia and things like that. So, like all things, it needs to be interpreted carefully, but generally what I've said is true. So, for a younger person under 40, I would be aiming for a HbA1c of 48 or less. Now, for an older person, we might be aiming for an HbA1c of 58 or 53. But for those younger people, we really want to get their glucose levels as normal as possible, because that's what will reduce the chances of complications as we go along. So the diagnosis of diabetes, and the numbers I've given you, and there are glucose numbers as well, and that's also perfectly fine to use for diagnosis, is based on the risk of retinopathy. So the risk of problems at the back of the eye, which tend to increase in an exponential way once your HbA1c rises above 48.
Thank you. And I guess that's the damage in the back of the eye is kind of representative of the small vessels throughout the body.
Yeah, that's right. That's right. That's right. So, so the eye is the window on the world, and yes, it does give you an idea, certainly. But also the level of detection of retinopathy now is amazing compared to what it was. So we often will find that someone will have what we call background retinopathy. It's the most early stage of retinopathy, and that will come and go. So I wouldn't want your listeners to be panicked if they look back at their retinal screening and they see they have background retinopathy, particularly in one eye, and that doesn't mean that they're on a concerning path necessarily.
Sure. Thank you. Well, I've been listening out to try and understand what your take-home message might be, so I'm going to try and guess it. And I think it's something around, look, lifestyle change is so important, or active and calories that meet your expenditure, shall we say, is so important. But actually, we need to be realistic, and if people, and we can't support people to make those changes, we should be biting the bullet and looking to medications to help us, because we've got some really, really safe, effective medications, and diabetes as a condition can genuinely be managed effectively, and these horrendous complications we talked about prevented through some simple measures.
Yeah, so I think we need to be looking at treating the whole person. And one of the elements we haven't touched on at all is the sort of psychology of living with diabetes, which is significant. So diabetes, both main types, can have a significant psychological impact on someone, how someone sees themselves and how they see everything that they do. So that needs to be borne in mind. But one needs to look at the holistic treatments, and lifestyle at every stage of managing diabetes is really important. But medication does not mean failure. Medication often means that the condition has progressed despite best efforts. And our job as clinicians is to be a guide, not a judge. We are there to guide someone along their journey, not to judge them. And often the way I like car analogies, Nick, I don't know why, but anyway. So I often say to people who come see me, I say, look, you're in the driving seat of your health. You're in the driving seat. Every now and again, someone like me will get into the passenger seat and maybe suggest that we turn right, left, or go straight ahead. But when I get out, you are still driving. And so it's really important that what we recommend to people is doable within their life, and that we don't set targets that are completely ridiculous. So I often see, sadly, or not often, but frequently enough to make me think about it, people that will have a very high HbA1c, and the healthcare professional is saying, well, in 3 months it needs to be down to the numbers I've just quoted, like 48 or something. That's impossible. So why set a target that as a clinician is impossible to achieve, and that the patient will come back having not achieved it and feel bad? So I often will set an interim target that's achievable, because long-term conditions management is a partnership, and we both have to be willing partners in that endeavour. And we have to use, in my view, whatever methods are necessary in order to help the person to achieve their goals. And it might be the person says, actually, I don't want to do that. So we mentioned about bariatric surgery, and I don't think that's used anywhere near as often as it should be in this country. I think people living with obesity in this country are stigmatized more so than other countries. And, for example, France does about 10 times the amount of obesity surgeries than with a similar size population. And I think very often people don't think of it, or think that lifestyle is the only thing that should be done. And if you can't do it through lifestyle, then you should try harder. And that's just wrong. Mm. We wouldn't use that for any other long-term condition. So if we saw someone with high blood pressure and we recommended a trial of lifestyle and it didn't come down, we'd give them a blood pressure medicine, wouldn't we?
Absolutely.
Yeah. So we should do the same with managing weight and type 2 diabetes.
Thank you very much. Well, on that, we'll end it. I don't want to make people endure us any longer, but it's been fascinating talking to you. Thank you for your time.
Pleasure.
And,
pleasure.
And we'll put some more information on the website, because I know what we didn't touch on is the other support out there, like the charities.
Absolutely.
How, what questions to ask your doctors, etc., etc. So we'll put some links.
I'm happy to come back and do another one.
I think it will be well worth it. Thanks very much.
Pleasure, Nick.
You've been listening to the Health and Wellbeing podcast, where today's focus was on type 2 diabetes in adults under 40 and the complexities surrounding its management with Dr David Lipscomb and me, Dr Nick Harvey. If you have any feedback or suggestions for future episodes, please email us at sdhc.feedback@nhs.net. Please take a moment to subscribe to help support us in empowering others with their health and wellbeing.